Okay, so we're starting again. Welcome back, everyone online. So we are now moving with our first panel discussions, and we are turning our attention towards the genomics in maternal and child health. In this panel discussion, I'd like to introduce to you Dr. Jan Friedman. Thank you. He's going to help us chair this conversation on how genomics is reshaping care for mothers and children, and is going to highlight in the conversation advances from national asthma studies to groundbreaking work at BC Children's Hospital and beyond. I just want to say a few words on Dr. Jan Friedman. Is a leading clinician scientist whose work has helped shape the science and practice of medical genetics. From pioneering the use of genomics to diagnosing intellectual disability to advancing our understanding of medication safety during pregnancy, Dr. Friedman has made a lasting impact on patients' care, research, and education. And as the moderator of this discussion, he's going to now introduce to us all the other panelists. Welcome.
Thank you. What we're going to do is to have three brief talks by our speakers. Before each talk, there will be a Slido question for you. The responses to those will be given after the three talks. Then we will have some questions to the panelists and open the session to everyone, both online and in the room. So, our first speaker is Dr. Sylvie Langlois. She's Professor Emeritus with the Department of Medical Genetics at UBC and the Medical Director of the BC Prenatal Genetic Screening Program. She's contributed a tremendous amount to the field of prenatal diagnosis using genetic and genomic tools for a variety of diseases, and has been a national leader in developing this technology and certainly in implementing it. So the first question before Dr. Langlois begins, this is the first Slido question, and we'll ask you to answer this. The question is, given the higher cost of cell-free DNA testing, which you'll hear more about, versus standard maternal blood screening for fetal aneuploidy, chromosomal abnormalities in the fetus. But the very high cost per case found, the benefit to the families and the healthcare system for each case found, should MSP pay for cell-free DNA if pregnant people strongly prefer a more accurate and earlier test? Also a safer test. Yes or no? So, Dr. Langlois.
So first of all, I'd like to thank the organizers of the symposium for giving me the opportunity to share with you what has been my passion for at least the last decade. And Genome Canada and Genome BC were funders of this work, and certainly this big project wouldn't have been able without that. So I want to thank them very much. This project I want to talk to you about was the Pegasus project, and I had really the greatest opportunity in my career was to work as co-PI with François Rousseau, who was the kind of lab genomics strength of this project, and I was the clinician scientist and clinical geneticist that brought this clinical trial to success. So as Marco mentioned in his talks, you need to have leaders in both fields, the users and the genomics people, to bring something to implementation. So what are we talking about? Essentially, it was recognized sort of around 2010 that when a person is pregnant, there's actually circulating cell-free DNA in the blood that comes from the placenta, so is a reflection of the genomics of the fetus. And with the advent of next generation sequencing, it became possible to actually measure the amount of cell-free DNA from each chromosome, both maternal and placental or fetal, and determine if there was, compared to a normal pregnancy, if there was an excess for any chromosome, which would predict a high risk of having an affected pregnancy. And so the first project we did, Pegasus 1, essentially demonstrated that we could implement in our Canadian laboratories this new approach to screening for the common aneuploidies, because we could separate the affected pregnancies from the normal pregnancies with very minimal overlap, which meant very few false positive and an incredibly high detection rate. So this was referred to, or is referred to by many, as non-invasive prenatal testing, or cell-free DNA-based prenatal screening. This new technology was implemented and funded in not all, but most provinces of British Columbia, and most provinces of Canada, as a second tier test. So let's say we look at the situation in BC. We have about 42,000 pregnancies. We offer them the standard screen, which is a combination of 2 blood tests where we measure analytes that are not genetics, but are analytes that come from the placenta and have slightly different levels between normal and affected pregnancy. We combine that when, for not all, but higher risk women, with a measurement in the back of the neck, the nuchal translucency, and we come up with a risk of Down syndrome and trisomy 18. Those who screen above cutoff are then offered a non-invasive prenatal testing, as it is a highly accurate way with very few false positives, as I've mentioned, to essentially then determine who is, out of all these 2,400 positive screen, which one are more likely to be true positive, and we offer those women invasive diagnostic testing. So pre-NIPT, these 2,400 women would have been offered invasive diagnostic, which came with a risk of pregnancy loss, and now we've added NIPT. So following invasive diagnostic testing, we obviously identify the true positives and then provide women counseling and reproductive options. So the real question with the study was, could we move from implementing this as a second-tier test to really implementing it as a first-tier test, comparing the essentially clinical utility of moving to first tier, also determining if we are doing a whole genome approach to the sequencing, may it be at very low coverage, can we not only screen for the common aneuploidies, but also screen for any significant chromosomal rearrangement, deletions and duplications? So that was and is that cost effective? To do this, we really need to look at LC issues, and is that what pregnant patient and society wants, and how can we make sure that everybody makes an informed decision? So there was an entire pillar looking at scaling up strategies for shared decision-making tools. And then how can we improve the technology? How can we make it more affordable was another pillar. So I would like to share with you sort of the results of the study that I was most directly involved. And so how can we improve the technology? One of the big problems with this technology when we first started is there was a significant number of no-call rates. So if we were to go to first tier test, what would we do with this 2% of pregnant women who don't get a result? This no-call rate was largely due to a low fetal fraction. So if we're looking at about 10 weeks gestation, about 10% of the cell-free DNA represents the placenta, and there's quite a range at that, with about 2% that fall below the 4%, which is felt to be the lowest fetal fraction to have reliable results. And one of the big factor involved is actually BMI, larger BMI being associated with much significant higher risk. So a lot of work was done to try to enrich for fetal fraction. How can we essentially ensure that at 10 weeks we have sufficient fetal fraction in all or almost all pregnancies? And this was achieved through an in vitro selection assay through essentially sort of the fetal fragment is shorter than the maternal fragment. And so by essentially doing a gel selection, automated gel selection, one was able to significantly increase fetal fraction and from an average of 9.8 to 18.6% in the first trimester, reducing no-call rate to a very minimal rate. So that was a very big achievement because increasing fetal fraction will also allow us to actually be able to sequence more libraries in the same lane, and so also decreasing cost. And then you can see here that with enrichment, we also separate our euploid from our aneuploid cases much better. So by reaching higher Z-score in our aneuploid cases, we will also have higher detection and lower false positive rate. So essentially, the randomized clinical trial was done so that we could demonstrate or actually see whether or not there's a true benefit or what is the benefit of essentially moving from second tier, so standard of care, to first tier. And so this was essentially a randomized clinical trial with women being randomized 2-to-1 to the intervention versus the standard. And they were followed throughout their pregnancy to collect data as well as questionnaires to look at prems and proms, so their experience, their sort of well-being during the study. And what we were able to demonstrate is essentially that 98.7% of women are reassured earlier, because the majority of women have unaffected pregnancies and get a result at 13.5 versus 16.1. And there's more of them that are reassured because our false positive rate is much lower. So significantly less unnecessary anxiety. We have more cases of aneuploidy detected. We have earlier diagnosis, so we have screening results earlier. So obviously those who are positive have an invasive test earlier than in the standard screen. And it's a more efficient screening algorithm because, as you can see, it's not 2 visits for 2 blood tests. So essentially, one big part, a big issue with implementing cell-free DNA as a first-tier screen is the cost. So a lot of work was done by Dr. Russo's lab to try to reduce the cost, addressing absolutely every step of the process, including, sort of reducing the cost of the tubes and DNA purification, making everything automated. And in fact, the current cost is cost-effective. But one of the big issue is the license fee, which is extremely significant in terms of the total cost. And this was achieved in part by being able to do sort of fetal enrichment and increased number of libraries being sequenced at the same time. So the next question is, what do we screen for? And work done by one of our co-investigator in Belgium, who was the leader there to implement first tier and IPT, and over the years has accumulated experience with a large number of pregnancies, has shown that it is possible with this technology to detect not only common aneuploidies, but also chromosomal abnormalities that represent just small segments that are deleted or duplicated. But these are very rare events. And the positive predictive value of a positive screen is not as good as with the common aneuploidy because they are a rare event. But still, for any positive result, about 50% of them are true positive for this segmental aneuploidy. And when we look at rare autosomal trisomies, which are more common positive screens, the PPV is much lower because them being truly fetal is even a rarer occurrence. So this work fed into the pillar on cost-benefit analysis. And And this was led by Dr. Danielle Renarts from Université Laval, who, with the use of supercalculators, was able to look at the cost effectiveness of including more chromosomal anomalies in our screening than the common aneuploidies. And this included sex chromosomal aneuploidy, all segmental aneuploidies greater than 7 megabases, rare autosomal trisomies. And he and his teams were able to demonstrate that at a willingness to pay of $50,000 per each additional case, then there was a high probability of being cost effective to include all conditions. Finally, Dr. Legaré led the team that was looking at really making sure that patients make informed decision and developing sort of this decision aids that facilitate sort of healthcare providers supporting patients in making that informed decision through either a paper format or a web-based format. So that was the role of the Pegasus study, trying to move forward cell-free DNA screening to first tier, demonstrating that it's possible, that there's clinical utility, but at the moment there's still an increased cost. Does that polling sort of questioned? I wouldn't want to end this session without at least giving a few words to genomics in the field of not screening, but prenatal diagnosis for rare diseases. So we were talking before about sort of common chromosomal anomalies or rare chromosomal anomalies, but a significant proportion of the patients who present with fetal anomalies actually have a single gene disorder. And genomics has very much moved forward the ability for clinicians to make accurate prenatal diagnosis in those cases, allowing sort of families to receive a diagnosis prenatally and consider all reproductive options. And so essentially, when we used to see families with pregnancies affected with fetal anomalies, we would offer them chromosome analysis and microarray analysis to look for copy number variants. And the advancement in genomics now allows us to offer these couples prenatal trio exomes to look for single gene disorders. And a number of studies from our center and throughout the world have demonstrated that one achieves a yield of about 29% when a fetus presents with multiple anomalies, 15% for a single abnormality, with some anomalies even isolated, having up to 30 to 50% yield. So very high yield for brain anomalies, for example, for some cardiac abnormalities. So genomics is really changing the field of both prenatal screening and prenatal diagnosis. It's allowing us a more effective and earlier screen for chromosomal anomalies. It's allowing us to diagnose single gene disorders, which we weren't tackling prenatally till about 5 to 8 years ago. And some groups are even advocating exome analysis in all pregnancies, and certainly that's being offered in some areas of the world, like Israel, as a way to not diagnose, as in you don't have an affected fetus to diagnose, but to screen for single gene disorders. So genomics is very much changing the field of prenatal screening and diagnosis and providing couples options that were not available to them before. Thank you very much.
Our next speaker is going to be Dr. Stuart Turvey, who is a pediatric immunologist at BC Children's Hospital and professor of pediatrics at UBC. Dr. Turvey is internationally recognized for his research in developing precision health-based strategies to address childhood asthma and other allergic diseases, as well as on discovering and describing a number of new inborn errors of immunity. So the next Slido question, if you can read it, is the non-communicable diseases are communicable? Yes or no? Dr. Turvey.
So it's a huge honor to be here. We're going to change pace and we're going to talk about dirty diapers now. So I'm a pediatrician. I see patients in the clinic, and we as pediatricians are very concerned about asthma. And so let me just give you some numbers. So from the 1980s to the 2000s, we had tripling of the rate of asthma, and we thought we were living, and we talked about an asthma epidemic. Asthma is the number one reason children access the healthcare system, go to our emergency rooms. Number one reason why children and their families miss school. So asthma is really a disease that matters. And, we've had decades now of epidemiology trying to understand what's happened in this one generation, really, from the 80s to now. Why is this happening? And I think we recognize in this audience that the host genome really hasn't changed that much. I'm not so different from my parents, but our environment is very different. And when we start boiling down those environmental factors, we often come back to hypotheses such as the hygiene hypothesis, the idea that we're missing exposures to the natural environment. If we live on farms, we're protected. If we have more antibiotics, we're at higher risk. If we're born to larger families where the kids bring home more infections, we're protected. And so when we start thinking about that, maybe when we look at the mechanism underlying some of this epidemiology, it's really about exposure to microbes. And I think we're starting to appreciate that the microbes, our microbiome, is that other genome that we really should think about because the numbers are impressive. Our microbes bring many more genes to the table to do functions than we do as our human host encoded genome. And so now I think there's been a lot of effort to try and understand how the microbiome is linked to health outcomes. And for pediatricians, and particularly for those of us who are interested in studying immune-mediated disorders like asthma and the allergic diseases which are caused by the immune system and a confused immune system, there's huge parallels between what happens with our microbiome and our immune system. So a baby's born, is essentially sterile, and then is exposed to a huge number of microbes which colonize our body. And at the same time, the immune system has to adapt from being in this enclosed environment to being able to protect the baby from infections. And so we have very much a two-way street of training that happens between the microbiome and our developing immune system. And so it's really with that background that the microbiome seemed to be important for immune development, particularly important for allergic diseases. We started on a journey to try and unravel some of those relationships. And the engine that's driven that for us has been the child cohort study. And I think maybe one of the themes we're going to see today is that some of these larger initiatives that bring us together across the country and even globally are the engine that drives forward our genomics discovery. And Marco reminded us that we as a country have trouble funding and supporting these longer term, broader initiatives. Child studies, a broader initiative, faces all those same challenges, but it's been remarkably powerful. So launched in 2008, we recruited pregnant women from 4 sites across the country. We started with about 3,500 very generous families, and we've been following them up incredibly diligently. And in fact, the children are now turning 16, and so we'll be bringing them back again to look. We've collected detailed clinical data as well as biological samples longitudinally. We boasted 92% retention at 5 years, and we're still well above in the 85% range now, more than a decade later. And I'd like to acknowledge that the powerhouse behind this work now is the director of child study, Dr. PJ Subarao. And again, child studies supported generously to get started by our federal funding colleagues and then further empowered by Genome BC and others. And so it was really by chance that we collected the microbiome. Honestly, when we planned back in 2005, 2006, people said, those bugs in the stool might be important and, families will probably give us diapers. And so remarkably, we collected those biological samples, froze them away, and they've been a treasure trove for us to interrogate from a genomics perspective. And over the years, we've used different technology, initially amplicon sequencing, 16S, and then more recently metagenomic sequencing, and then laying on other omics technology, metabolomics and others to really understand what's going on. And I'll just show you a couple little vignettes. So from our early studies, we had a very good look at antibiotics because they're clearly a huge modifier of the microbiome. And we found that in the child study, it's about 1 in 5 children were receiving systemic, so oral or IV antibiotics before their first birthday. And strikingly, receiving those antibiotics was associated with doubling or tripling the risk of being diagnosed with asthma at age 5. And we were able to use our 16S data to show that those antibiotics were causing microbial dysbiosis, so imbalance of the microbiome in the gut of those children. And so this was really a call to action to be very thoughtful about the use of antibiotics. And David Patrick from the BC Centre for Disease Control has been a huge advocate at mobilizing this story and mobilizing it as part of an antibiotic stewardship message. So that was fine, but and we can be very careful with antibiotics, but some children absolutely need antibiotics, and we can't abolish all use of early life antibiotics. So the question is, well, what can we do to protect the children? What are some of the factors that might prevent this antibiotic-induced asthma? And it's obvious, really, when we think about that the superfood that children receive early in life is breast milk. And breast milk is profoundly important for many health outcomes, but very important for the development of the microbiome. And in fact, when we look at the structure of human milk, about 30% of the carbohydrates are in the form of human milk oligosaccharides. So these are sugars that we as humans can't break down, but the bacteria can. So a huge amount of maternal energy is going into developing what is essentially bacterial food. And so I think that's telling us an important evolutionary message about the relationship between human health and a healthy gut microbiome. And so we were interested in this. Well, what about breastfeeding, and what did that do about this antibiotic asthma risk? And I'll show you some data. Hopefully you can see that. But we broke up the group, those children who received antibiotics whilst at the same time receiving some human milk. It didn't have to be exclusive breast milk. It didn't even have to be fed at the breast. It could be pumped and delivered. And I think the results are really striking. So here at the bottom two on this forest plot show the risk of being diagnosed with asthma if you have one course of antibiotics in that first year, so almost 3-fold. And then if you have 2 or more courses, up towards 8-fold. But if you received any breast milk at the time of those antibiotics, those infants were completely protected from that further development of asthma. And so we worked on this, and we're impressed by the remarkable superfood effects of breast milk, protecting against antibiotic-induced asthma, rebalancing the microbiome. And as we've dug into the data more deeply, one star microbe turned up, and that's Bifidobacterium infantis. So Bifidobacterium infantis seemed to be the central player that was offering this breast milk protection. And also recognizing that breastfeeding isn't possible or successful for every infant, we were able to identify some specific maternal HMOs, some specific breast milk sugars that seem to be able to boost Bifidobacterium infantis. And again, information that would be helpful as we optimize human milk substitutes, as we optimize formula. So in the last minute or so, I just want to really build on what Shelley Joseph told us this morning. She told us and taught me the term nummoyet, meaning all of us, and how we need to be thinking globally. And so I really think we also need to be thinking about that in terms of the microbiome. So we worry, I hope we worry about loss of biodiversity. We worry about charismatic megafauna, panda bears and polar bears. But I wonder how many of us worry about the loss of bacteria. Do you mourn the loss of bacteria? When I went to medical school, all I learned about bacteria was they were bad, and I learned how to name them and which antibiotics killed them. And I hope we've moved on and realized that the bacteria that live with us and on us are very important for our health. And the emerging star, I said, is Bifidobacterium infantis. It's a supercharged bacteria that's designed to metabolize human milk. And we're losing it across as we become more industrialized. And we can see that on that bar chart as we move from non-industrialized to industrialized communities, that pink B. infantis is lost. And so it's a star that we are missing. And breastfeeding by itself is not enough. These are data from the child study. So 16% of Canadian children have B. infantis in their stools, are colonized in that first year of life. And we were pleased to see that about 80% of child participants were breastfed, but still that dark blue says that breastfeeding is not enough. And what's also remarkable about B. infantis is actually a health inequity that has become very clear from our data. So B. infantis is profoundly protective and profoundly beneficial, but when we look at our child study data, we see that it tracks very strongly with socioeconomic status. And so in the left, we can see family income. The families with the least income have the lowest rates of having B. infantis, and there's a stepwise increase. We can look at more sophisticated ways to measure socioeconomic status here by quartiles, and again, the same measure. B. infantis, this powerful and health-promoting bacteria, is at lower levels in families with lower health resources. And so where we're looking at that now is the fact that the gut microbiome is modifiable. There are things we can do about it, and it may represent an underappreciated tool to mitigate health inequalities. So to finish, what's the call to action? What can you do? There are many things we can do as parents, grandparents, physicians, health providers, policymakers. I think we can look to introduce that healthy microbiome, encourage vaginal delivery if that's safe and appropriate, do things in our society to promote successful breastfeeding. We think about rewilding our urban environment. To maintain them, we need to be cautious of antibiotics and cherish them. We again need to think about breastfeeding as a superfood. And then there's research ongoing to see if there's ways we can intervene to bring back health-promoting bacteria, maybe through supplementation and other strategies. And so with that, I'll end. I particularly want to acknowledge the families of the child study who have stuck with us for more than a decade so generously, and to acknowledge the funders that support this work, and particularly grateful for Genome BC to be with us for thick and thin, and for tolerating me when I had trouble knowing what the difference between a milestone and other readouts were. So thank you very much.
Thank you, Stuart. That was terrific. Could we have the next Slido presentation up, please? Our next speaker is Dr. Evelyn Stewart, who's professor in the Department of Psychiatry at UBC and the founding director of the Pediatric Obsessive Compulsive Disorders Clinic and Research Program at BC Children's. Her research focuses on biologic, phenotypic, familial, and treatment aspects of childhood onset neuropsychiatric disorders, such as obsessive compulsive disorder. And her Slido question is shown here now. When prescribing for an individual child psychiatry patient, pharmacogenetic data are best used to inform the prescriber about which medication will work best, the starting dose and rate of increase, the risk for specific toxic effects, and or B and C. Evelyn?
I'm so pleased to be here. I think what you might notice is that some of these talks are not like the others. Sylvie and Stuart just presented great talks about some of the findings and applications of work that has been done in the last 10 years or so. I just wanted to also acknowledge that the lands that we are in, the Coast Salish peoples, and I really appreciated the start of this session. So when I was asked to be part of this panel, I thought it was kind of a mistake, maybe, I don't know, misplaced email. So we have plans. There's things that we're wanting to be doing in the next decade or so. But in one of the guidelines, focus on results, actionable results, ways in which you've changed the field and the studies you've been involved with. And that's where I was quite sure it was a mistaken thing. But nonetheless, what I'm wanting to go over now, I'm going to quickly go over a number of slides, also recognizing that this is a very genetic and non-lay audience. So first of all, I think it's very important to be aware. Certainly, I think the media is finally becoming aware of the importance of psychiatric disorders when considering societal burdens of disease and global morbidity and mortality. We know that lifespan on average is shortened by 10 years for those with major mental health disorders. Most of these have child or adolescent onset. And unfortunately, about 1 in 5 children in Canada have a mental illness. Treatment outcomes are sadly limited by, accessibility, I think is probably the largest ones, but also low response rates and adverse effects, such that long-term cures are rare. And there have been sort of relatively few new insights, I would say, in the last decade or so. Another challenge that we face, so I'm a clinician researcher, I suppose. So clinically, we face a challenge in that diagnoses are based on signs and symptoms, and we don't benefit from actionable biomarkers necessarily. And we could debate about that a little bit later if we want. These also run in families, so this is partly why I'm here. It's been known for eons that there are families where there's a major mental illness that runs through these families. This has been known for a long time. There's advances in terms of sorting out whether that's environmental or actually a genetic effect with a number of twin studies that have been done. I've just noted a few heritability estimates there for autism, up to 80%, for ADHD, a childhood onset psychiatric condition, 75%, and depression, quite a bit lower, around 40%. The candidate gene studies presented great promise, and this is when I was living in Boston, and I'd been doing clinical work, wanted to do research, and then I discovered candidate gene studies, and I thought, this is so easy. It's like fishing. I was publishing in biologic psychiatry, molecular psychiatry. How could it be that, I just think of what gene I want to look at, and then boom, one of the SNPs of 50 SNPs that I've looked at has a positive finding. Obviously, we learned there's many false positive findings. There's inappropriate correction for multiple testing. So I think some of the initial excitement waned a little bit. And then with the advancement of higher throughput technology, application of statistical standards, and collaboratives, I think there have been many gains since that time in the last 10 to 20 years, and largely thanks to the PGC. You guys know all of this, so I'm just going to skip that slide. You know what a GWAS and a whole exome sequencing, yeah, you know all that stuff. Okay, so in terms of recent insights around psychiatric genomics, overall, and this is largely work by the PGC and thanks to international collaborations, that in looking at the burden of mental illnesses, many of which are comorbid or multimorbid, as we're now starting to say, the causation is largely driven by many common very low penetrance variants, some rare high penetrance variants, but only in specific disorders, and then they're found throughout exons, introns, and intergenic regulatory regions. We know there's a strong overlap in terms of risk variance for psychiatric conditions. When you look at risk scores or predictive risk scores for one psychiatric illness, it's very highly correlated with that for other ones. So you might say, okay, well, who cares? But when you compare it with neurologic disorders, that's a whole, seems to be different kettle of fish in some areas. So what we're dealing with is a very highly complex set of illnesses that often co-occur. And that genomic complexity had historically been very underestimated, especially by me as a postdoc, when I thought we were going to figure out things and change everything super fast. So I think that's largely driven by the polygenicity and the pleiotropic effects of a number of the genes that are involved in psychiatric illnesses. So in terms of clinical genetic testing, takeaway, there's no simple genetic diagnosis for most individuals with psychiatric conditions. Autism spectrum disorder is the different disorder here, where there have been 250 genes and 12 CNVs with large risks that have been identified. Pharmacogenetics and pharmacogenomics have been a thing that have entered our clinics in child and adolescent psychiatry, typically with a parent coming in, handing you a form, expecting you to be grateful that they've given you the answer of what treatment needs to be. And they've got it very often with little traffic signals, red, yellow, or green. This is what's going to help my kid. This is what's not going to help my kid. Overall, I think the benefits of pharmacogenomics had initially at least been overpromised to consumers. However, they can be very helpful in terms of providing support tools for clinicians around pharmacokinetics or drug metabolism. So especially cytochrome P450, 2D6, and 2C19 are involved with metabolism of a lot of our commonly used psychiatric drugs. So certainly that can be helpful in terms of predicting slow metabolism or faster metabolism. Predicting toxic effects may also be some benefit. However, probably the most important thing, and I'd say probably a major thing that parents misunderstand, is that they don't necessarily predict drug effectiveness in the field of child and adolescent psychiatry or psychopharmacology. And yet, these pieces of papers or reports that are brought in may shift prescribing patterns away from evidence-based treatment because there's one certain med that's listed in the green column, even though it doesn't have proven effectiveness necessarily for a condition. So that, I think, is something for us to pay attention to. So now looking forward, in BC and Canada, I wanted to highlight a biobank project that's going to be started at BC Children's Hospital. The plans are to support current and future research efforts, lay a foundation for biomarker-driven diagnoses and management. This is being co-founded by Dr. Roberto Sassi and myself, with the idea being that for each child coming in for an initial psychiatric assessment, that they will be given the opportunity to contribute samples, including whole saliva and buccal swabs, and to create a biorepository. And we've done a pilot of this over the last number of years in OCD. In terms of aspects that we'll be looking at, genomics and epigenetics, are right up there. And then the other piece that's really important, Dr. Mara spoke about this morning, is linkage with databases, electronic health records. We've worked for several years to look at parent and youth-informed data around phenotyping, because if you don't have good phenotyping, it's very hard to apply that in clinically meaningful ways when you're trying to bring together these fields, and also population-level databases. And I think this slide represents the real reason I was asked to be here today, and I've got 15 seconds left. This is a project that's funded very much with contribution of Genome BC, thank you very much, Genome Canada. We haven't even gotten to the REB stage, but it's been funded to create a pan-Canadian study linking genomic, environmental, and mental health data. It's a very large-scale collaborative led by Paul Arnold at the University of Calgary, and we have a goal of sequencing 5,250 children and youth to contribute to a public library. This will include youth who are coming through our clinics, such as those through the biobank that we're creating, and also those part of cohorts. And I think the child cohort is part of that, using an equity framework. So we know this, whoops. So the research, the hope is that we can identify genetic risk and protective factors to inform effective approaches for risk stratification and targeted interventions. So I am glad to have been here, all of us. So even though some of us have not created actionable findings yet, we're very happy to be included, and maybe 10 years from now or 5 years from now, I'll be able to provide the slides that show some actionable items from our combined efforts. Thank you.
Thank you very much, Dr. Stewart. Could we get the answers to the 3 Slido questions we had? So this was Dr. Langlois' question. 82% said yes. So Dr. Langlois, we need to get her back online, but I think that is support for her position. The next question, please. Non-communicable diseases are communicable. So I think you got that message across. That's very good. And the next question, please. When prescribing for an individual child psychiatry patient, pharmacogenetic data are best used to inform the prescriber about D, B, and C, which is the correct answer, I believe. So that's excellent. Very good. Now, we're going to have a discussion. We're supposed to have an hour. I think we'll cut that down a little bit in the interest of time. But we'll begin it with, we need Dr. Langlois online so she can participate in this. There you are. Good, Sylvie. And we'll begin with a few questions that I'll ask, and then we'll ask the audience to ask questions and to respond to the comments that the speakers have made. And maybe we'll start with a question to Dr. Langlois about how you see cell-free DNA screening for common aneuploidies being used over the next few years. Do you think it's going to become widely available as a first-tier test?
Well, I'm glad the audience was supportive of that, because essentially that's certainly my goal. I think it would, if it could move to first tier, it would need an extra investment, but it would essentially provide better care to pregnant people. I'd like to point out that at the moment, about 40% of pregnant individuals purchase the test through industry. And as such, I think have earlier results and better care. And so there's great inequity that I hope that we will be able to change by making it available to all people. So that's my goal.
You talked about a license fee that was greater than the actual cost of doing the test. Is there anything thing that can be done about that, or is that going to expire in the foreseeable future?
I don't know the answer to that. I think we need to go back to industry and see if that can be renegotiated, because proportionally it makes no more sense. I mean, when we first started, that license fee was a smaller fraction of the total cost. But sadly, I mean, that's what we've seen in genomics for other tests, as you know.
Yeah. Are there comments or questions for Dr. Langlois? Yes, Steve.
Thank you, Sylvia. That was a great talk. And I think over the years, you have, Jan has, many others in this room have been in meetings where we hand wring over the cost of a test. And often that cost is what's the cost to the unit, or conceivably what's the cost to the hospital. But we don't often consider the cost or the value to society that test is giving. And I think when Genome Australia was formed, it went to the government and they didn't say what's the cost of genomics, they said what's the value to society. And one example here, and this is why it's such a great investment in prenatal testing, is if you do have a severely disabled child, as such could be caused through an aneuploidy, the cost to the Canadian taxpayer over that person's life is over 20 million Canadian dollars. So in some ways, the best investment the province can make is by having a robust and accessible and cutting-edge prenatal testing, right? And we shouldn't have to worry about, the license fee that much as kind of look at what the true value is to society in BC.
Stephen, I couldn't agree more with you. Very sadly, our politicians and those who make those decisions are very much siloed with the Ministry of Health considering their budget as opposed to all ministries, or the impact to education, long-term care, and all other aspects of having a disabled child. I also want to point out, though, that the benefit of screening isn't limited to just reproductive options and the consideration of interrupting pregnancies, but also the benefit of managing those pregnancies more appropriately and providing those children or those families who choose to continue their pregnancy the appropriate care. Not being delivered in the smallest center in BC when you have a child, a newborn with Down syndrome and a heart defect, for example. So there's a lot of benefits to society to having earlier screening and earlier diagnosis. I think we're going to move to even fetal therapies for a number of genetic diagnoses within maybe not my lifetime, certainly not my career, but it's a reality. There's a lot of trials going on for the treatment of thalassemia in utero. And so we need to think broadly and move genomics diagnoses earlier in pregnancies to provide more options to family.
And these fetal therapies are obviously not available unless you have a genetic diagnosis to begin with.
Exactly.
So this is critically important. Other comments for Dr. Langlois on this? Okay, maybe we can move on to a question for Dr. Turvey. We still haven't really worked out the genetic components of childhood asthma and allergies with respect to the host, with respect to the child. Are we putting the cart before the horse if we're worrying about the microbiome? Should we worry about the kid first?
Yeah, I think that's an interesting question, right? Why do we care about the microbiome? Why am I excited about it? And I think the reason is that it's modifiable. So there's something we can do. And if we sort of were to aggregate all sort of early life microbiome studies, I think what we're seeing is that disease typically goes along with loss of microbes. So the concept that we're missing microbes, missing health-promoting microbes, and their exposure early in life. And so recognizing that, I think, gives us a profound opportunity to intervene. When we have the list of missing microbes, there's the things we can do. We could do live biotherapeutics, give those bacteria back, or we could use what we call prebiotics, things that promote the growth of those health-promoting bacteria. So for me, this is why the microbiome is so exciting, because it's modifiable. I don't want to dismiss the host. I think host matters, and clearly, actually, host genetics also profoundly shapes the structure of the microbiome as well. And I think it may be one of the mechanisms by which we see host genetic change, ultimately linking to disease, including asthma and allergies.
That's much harder to interfere or change.
Exactly.
Yeah. What about socioeconomic status, which you said profoundly affects the microbiome? Is that an intervention?
Yeah, I mean, we came across these. We followed our nose to this story, and what I showed you, I think, was disturbing to me, in that this hugely important bacteria, Bifidobacterium infantis, was at the lowest levels in the Canadian families with the lowest socioeconomic resources. And I think there's reasons for that. In child study, we actually asked a question to the parents, and particularly to the mums. We said, were you breastfed? Trying to get at this intergenerational effect. And if the answer was no, I wasn't breastfed, that tracked with socioeconomic status and tracked with B. infantis. We also, for example, know that higher rates of antibiotic exposure, higher rates of cesarean section were experienced by those with lower socioeconomic status. So my sense is that there are many mechanisms by which socioeconomic status will influence longer health outcomes. But I do think one of them that's emerging is intergenerational loss of protective microbes. And so I think it's one lever we could think about, and I'm not suggesting just doing it for low socioeconomic families, right? I'm suggesting that if we work to bring back these microbes that we've lost over generations to the community, the ones who may benefit the most would be those of lower socioeconomic status. So it's something that we fell into really by following our data, but it really is a powerful signal.
Other questions or comments? Yes, Marco.
Thanks, Jan. These are terrific talks. Thanks to all the speakers. I just wanted to comment on Steve's question and go just a little bit further in that. In calculating the costs of things, we often base our cost models on what happens in research labs. And what happens in research labs isn't necessarily what's going to happen in the clinic. And so I just wonder about that. And I don't know of any data which would suggest that what happens in a research lab prior to implementation reflects in any way what healthcare systems actually pay for a thing. So I'll just raise that. But my question here is for Stuart. So this is great stuff. And the microbiome linkage has been appreciated across a range of different conditions. Do you know to what extent you can, with the specificity that you showed for asthma, where you feel it's boiled down to a bug, are we well, as a good candidate perhaps, are we able to say with any degree of similar specificity about impacts in, I don't know, type 1 IDDM, other sorts of immunological conditions?
Yeah, so that's a nice question. I think I posed this provocative question about non-communicable diseases because there's, I think, growing data around the importance, and for us, it's really about that early life microbiome. So setting the stage early as we have sort of waves of succession to build this large community And what we're seeing is that sort of traditional waves of succession that I guess we as a species evolved with have been disrupted. And so, for example, in our child study data, we see strong links with the structure of the microbiome to body weight. And again, it's often the same bacteria, so higher body weight trajectories are associated with missing microbes. And more recently, also some neurodevelopmental outcomes. And there's lots of evidence about that, the gut-brain axis. So I guess I'm just my plea is really to think about the microbiome as an important component of healthy development, and that we as a larger community should be identifying and respecting those bacteria. And by losing them, we're disadvantaging future generations of children.
Yeah, well, I wholeheartedly support exactly that. And I note that the microbiome linkage to cancer, to a range of different conditions, insulin-dependent diabetes, I mean, it's all there. We don't necessarily know what to do about it. But when we establish a cohort, we do a thing like the child study, there's an opportunity to think about all the different things that might be revealed if we could only contemplate the question right at the start of it all. And maybe this raises another important challenge, and we see this in the POG program. The breadth of consent under which the research operates can very frequently become a limiting thing. And so breadth of consent, I think, is really important to consider in all of these things. Because I can imagine in the child study with all the participants and the study that we heard about that is still to come from Evelyn, that we are scratching the surface with the knowledge we have today. And we're going to learn something tomorrow or the next day or the next week. And we're going to think, well, if only.
Huh.
So it's a major challenge, I think.
Yeah, I agree. Ultimately, we are always true to the consent that the child subjects provided. I think one of the advantages we had in the child study was this iterative and ongoing process of, so sure, we consented pregnant women during pregnancy, but then when we brought them back, we reconsented actually each time. And to add the layer of complexity on consent would be that the infants didn't consent, their parents did, but now as 16-year-olds, they've been assenting, but they will provide their consent. And so one part of our project with this had been really looking at that consent and working with Tim Caulfield and other health lawyers around, for children, moving through to competency. And so for us, it's been nice is that we have a strong partnership with the families. We have a strong advisory committee from the families, and we continue to do that. And so we have that luxury, which is different from many projects, which is, gee, I hope we get it right at the beginning so that we can do it well at the end.
That's very important. Other comments on this? Yes.
Yeah, so thank you. These were great talks. And I just want to say I'd like to emphasize two things. One is the bringing together of the genome of the human and the microbiome. This is really exciting because it can address some of these inequities. You're born with a genome, you're born with a certain socioeconomic status, but like was mentioned, the microbiome is modifiable. This is like a set of genes in our body that is more easily modifiable. And so we have a real opportunity here to sort of get people in a more equitable framework. There's also, the second thing I'd like to bring up is the challenge we have of bringing together genome data, administrative health data, clinical data, microbiome data. This is the thing that keeps coming up over and over again. And we really need to take it seriously to put some effort into doing this and doing it properly, following, fair with care, OCAP principles. I think there's a real opportunity here, and Canada is really taking a lead in many of these aspects. So I think there's a real opportunity that we could be innovative in this space.
Okay. Let's move on to a question for Evelyn here. You talked about the fact that both genetic factors and non-genetic factors, environmental factors, were important in the development of mental illnesses in children. How does this balance? Is mental illness really more nature or nurture? And if kids have psychiatric illness, is that because they weren't raised properly?
Good question. And that was a question that was asked of me. So hearkening back to a decision to do psychiatry rather than pediatrics, I think people made that presumption that, oh, you're clearly not interested in biology. You know, it's like interested in families, interactions, that kind of thing. And really, I mean, maybe it reflects my age, but that truly was a question, you know, nature versus nurture. Is psychiatric condition this, or is it that? I think, well, it's pretty clear. You know, there's a combination. I think that's reflected by heritability estimates and some population studies that have been done. One of my favorite recent studies in OCD, which is my field of focus, is a study looking at population cohort in Scandinavia, where they actually looked at rearing practices. So they're able to look at adoption and risk for, so with OCD anyway, it seems to be pretty clear that there's genetic risk factors. There's definitely a number of environmental risk factors, but if a step parent has OCD and then they parent in an OCD way, their child is at no increased risk of having OCD. If a parent who's never met the kid has OCD, raised totally apart, has OCD, that kid who they've never met is at increased risk. So I think, well, obviously, there's a lot to think about. I'm quite excited about epigenetics and looking at microbiome. So looking sort of beyond this sort of deterministic approach of, yeah, you're born with this set of genes, so therefore it's your destiny, or you're born in a family setting and then it's your destiny. Much more complicated than that, but it's challenging to study, but interesting.
Comments or questions for Dr. Stewart on this? Maybe I'll ask one to follow up here. So there's all this heterogeneity within the causes. There's heterogeneity clinically. There's overlap, you said, between the various conditions and one another. Can you use the genetics to break out the heterogeneity so we can understand subgroups that we might be able to treat more effectively?
Yeah, I think that's a great question, because yeah, there's heterogeneity on both sides with the genetics and also the phenotype. I think some of the work of the PGC has been really helpful, and some work on cross-diagnostics. Clearly, what we have now, which is a DSM to diagnose an illness, basically a set of man-made or man-defined symptoms, has not necessarily been that helpful. But and there have been efforts to look at sort of genomic signature to see if you can break apart diagnostic groups. I think there's some role there, potentially, but so certainly I think there's similarity found between bipolar disorder and schizophrenia, so it's been helpful in that way. There's similarities, say obsessive compulsive disorder and Tourette disorder. So I think there is some utility there, and quite frankly, I think we need to use all the information we have, which is why with that PanGem project, looking at things like longer term outcomes, future hospitalizations, future suicide attempts, in addition to socioeconomic factors, is really going to be important. So I think
it sounds like I'm hedging, but I think that the truth is, I think using many of these different tools that we have may be helpful in terms of breaking down a super complex phenotype into some sub-phenotypes that at least have a bit more homogeneity, that maybe reflects on or could provide guidance on best treatments. Because really, I think that's, in the clinical setting, that's what matters, if we can improve longer term outcomes in some way.
So you shouldn't apologize. You're giving an introduction to what you're going to be learning in this new study, I think. So that's terrific.
That's right, yes.
Okay. So, Marco, you have a comment?
This is to Evelyn. Do we have time?
Yes.
Oh, he's cutting me some slack. This is great. So you spoke about the establishment of Biobank, which is fantastic, and you spoke about the establishment of a national consortium under the CPHI framework, I guess. And I guess what I'd like to know, if we could boil it down into an answer, is what do you think the three biggest challenges that the network in its establishment has faced?
Yeah, okay. I think one of the challenges is sorting out what are necessary protective variables around how the data will be taken care of. How I think especially with things like 23andMe going under, people in general are more concerned now about their data being lost. And we're going to be asking for a lot of data from individuals. So trying to have an answer to people when they ask about how the data will be protected. I think interprovincial differences is going to be hugely problematic in terms of how this data is managed. The fact that data is going to be collected in certain provinces, sent to other ones, and I think we've optimistically said we're going to do our best here and apply. And fortunately, Genome BC has been so helpful. So it's going to be the sequencing site within our province. And then I think at the other end, I think the challenge is going to be trying to figure out how to do justice to all of this data. You know, beyond just saying AI, we throw it in and see what happens, but looking at the really important health indicators, you know, from these different sources, and looking at how deep you can go into, you know, deep sequencing and so forth, and trying to get an answer that we have some confidence in with what seems like, you know, 5,000 seems like a lot in some ways, but it also seems like a drop. So to not overinterpret what we're able to find. It's always a juggle. You want to know everything, and you can't, you know, you don't have access to a limitless cohort. So you want to get permission to do everything, but be protective or helpful to the people, and especially when you can't predict in the future what's going to be most valuable. I think that was 3 things.
Okay. So in the interest of time, I've been given the hook. And we're very grateful to all of the participants. In the future, we hope that we'll be a future session, next session. We hope we'll get the opportunity to get some questions from the online participants. But we're going to have to stop this one now, and we'll take a 10-minute, I think, break.
Thank you, Dan. Thank you very much. This was really insightful discussion. I want to thank you, Evelyn, Sylvie, and Stuart. This was great. Thank you so much. We do take a short break right now. Can somebody confirm? Sorry. Is it 10 minutes? 10 minutes break from right now, so we'll be back here and we'll shift focus with our next panel. For the online participants, you can access the next session by returning to the event hub and clicking the bottom for the rare diseases session. We will see you shortly. I will go straight to the point rather than continuing to encourage online people to use a Slido to ask questions. I will just directly say you're not asking enough questions this year. And I think the reason is that we have split this event within a hybrid and in person. So people at home perhaps are feeling really comfortable that we will fill the room with questions. But we need to see the questions on Slido. Thank you.